of distinguished guests in the audience. I don't have time to name them all because it would take up all of our time, so I'm just going to introduce our very special distinguished speaker, George Sheldon, who's the Acting Assistant Secretary for the Administration for Children and Families in the United States Department of Health and Human Services. He graduated from college and law school at Florida State University, and I might mention that the Seminoles broke my Blue Devil heart this season. I believe, although he's a gracious man, he gave me this 3 times last night at dinner. Just bear that in mind. Secretary of the Florida Department of Children and Families. I'll say more about that in just a minute. Before his work at DCF, he practiced law for 12 years, served in the Florida legislature for 8 years, served as a law school dean, and was Deputy Attorney General for Central Florida, where he managed 5 regional offices. He's 187 years old, as you can tell. As the Secretary of Florida's Department of Children and Families, he oversaw the state's child welfare programs, in which he fostered a 36% reduction in children in out-of-home care, integrated mental health, substance abuse, and domestic violence services throughout the department. He also, during his tenure, Florida achieved the nation's highest rate of adoptions among foster children for 2 years. He took the lead in improving services for children, for the youngest children, by eliminating the use of group care for children under the age of 6, and provided enhanced attention to teens who were aging out of foster care. As gifted leaders do, during his tenure as secretary, he united various factions in the state of Florida. In the course of making profound changes in the state's child welfare programs, he enjoyed the respect and cooperation of legislators, advocates, the media, the governor, and especially the staff of his own agency. In early 2010, he worked closely with federal partners at HHS and ACF to provide aid to victims of Haiti's catastrophic earthquake. Florida and ACF met the needs of more than 27,000 American citizens, 700 medical evacuees, 600 Haitian children who were moving through the adoption process into American families. We are pleased and honored to welcome Mr. Sheldon to Tulane. So I think you can clip this on.
Pardon me?
Clip it on your tie or something. Clip it on his tie, is that?
This is, don't cover the tie? Thank you. First of all, Charlie, thank you, and it's good to be here, and I appreciate those kind comments. I mean, basically, what you have just discovered is that I can't hold a job, and it was particularly good to spend time at St. Thomas Law School for about 4 years, and where it really kind of took me back to my days in law school, but it also it reminds me of how important public education and private education is, and what you learn in institutions like this. I am particularly pleased to be here in New Orleans and empathize with what you've been through, with the devastation of Katrina, the recovery after Katrina, and I think at the law school we actually had some students from here who spent some time with us while Tulane was getting back together. And then you were hit a second time with the oil spill and the impact on that on Louisiana. We were dealing with that in Florida as well. But there's an amazing resilience in New Orleans, an amazing resilience that you have, and I think it really points out that as human beings we can get over devastation, and we can pull ourselves together. You know, it is so important when you really look at government. It is so important that we look at the impact that we have on children, because they are, and this, you know, I think sometimes we say this tritely, but in reality they are our future. And the better we can do in early childhood education, the better we can do in child welfare, the better we can do for our children, the better off we're going to be as a society. And that, I think, goes without saying. I think the good news is that the child welfare system in this country has made significant improvements over even the last decade. The number of children who are coming into care and who are in out-of-home care is reducing across the country. Every state in the country, with the exception of Arizona, has had a reduction of children in out-of-home care. And if I learned anything, having run the system in Florida, I have learned that in general, the state is not a good parent. The state is not normal as a parent. And I think we've got to recognize that as an issue. We have got to admit that if we bring a child into care, we've already failed that child. And that anything that happens after that is the best of all possible bad alternatives. When I first got to the department in Florida, I had a legal background. I served in the legislature, was in the Attorney General's office. And when I came to the Department of Children and Families, I sat down with about 15 young people who had aged out of foster care. And it was one of those kind of things, it was kind of on your schedule. So I thought, well, I'll go by for about 20 minutes and then move on to the next event. 2.5 hours later, I think I learned more from those 15 young people than I've learned from all the professionals in child welfare. And I'm not taking anything away from professionals, because I think they bring a lot to the table. But we designed a whole child welfare system in this country, and we never talked to kids. And who have more to offer, who have more to bring to the table than young people? And I think a lot of the work that Dr. Zena has done and other researchers on the impacts of trauma on young children is we very well recognize that children are very vulnerable and very susceptible to what's going on around them. And if you look at the child welfare system, there's the trauma that child is undergone in the home, but then there's the additional trauma of removal from the only home they've ever known. Then the additional trauma is that child may be moved from home to home to home to home, or school to school to school to school. And I think that I really would like to thank Dr. Zena and his team, as well as other researchers who brought so much attention to this area. We in Florida listened to that research, and we learned from that research. And now at the federal level, we are learning from it as well. And in Florida, we changed foster care as a result of what we learned from the research. Brought Dr. Zena down, I think, 7 or 8 times to Florida to work with a lot of our case managers. And it was a lot of that research that really led me to a belief that we really have got to the extent possible, make children's lives as normal as possible. And being in foster care is not normal. Being in group care is definitely not normal. And it was the reason that I felt, at a minimum, we ought to be discouraging shift group care, but definitely not allowing shift group care in children under the age of 5. It is not normal to have your parents change every 8 hours. And that's in reality what shift group care is. I want you to know that we have learned from a lot of the research. We know that the best policy development is informed by the latest and the best research. So we at the federal level are constantly trying to integrate theory into practice. And that's why it's so important to maintain this kind of constant dialogue. Too often, we have engaged, those of us engaged in practice in child welfare have been driven more by philosophy and politics and expediency rather than solid research. And all you have to see is how systems react to a child death. You don't even have to have a policy change. There is an automatic backlash to a child death that expands beyond just that one case. and you will see with a child death an automatic increase in children coming into care. And because too many times I think systems around the country will attempt to circle the wagons when a child death occurs, to hide behind confidentiality as a way of saying we've got to protect the confidence of these children. I happen to believe that transparency is ultimately the best way to deal with a crisis, because ultimately information comes out. Sunshine is the great disinfectant. And when something goes bad, I think it is better for systems to say we're going to learn from this and we're going to try to improve our practice as a result of those crises. Because, and this is, and you know this is probably a terrible thing to say, but no matter how good we get as a society, and no matter how good we get in child welfare, we cannot save every dysfunctional family. That has to be our goal. That has to be what we strive for. But in reality, that is something that may not ever be fully achieved. But I do think that the picture of child welfare in this country is shifting. As I mentioned before, in the last 14 years, the foster care caseload has shrunk in this nation by some 25%. Some 559,000 children 14 years ago to now only slightly over about 400,000 children. But I also think you have to delve further into those numbers. Though the total number of children in care has decreased in the last 5 years, about half the children entering foster care are 5 years old or younger. And of those, 1/3 is under the age of 6. And we know that the experience of young children in foster care is much different than the experience of older children. And that poses in and of itself a particular challenge. Infants in foster care stay longer. Those who enter before the age of 3 months old stay almost twice as long on average as an older child. They are more likely to be placed with foster families than in other settings. And they are less likely to be reunified with their biological parents and are more likely to be adopted. Too often the system responds to these kids' problems by medicating with the use of psychotropic medication. The Government Accounting Office study found just last year that in Florida, my home state, more than 5% of children birth to 5 were taking psychotropic medications. More than 1.5 times the number of non-foster children. In Oregon, almost 4 times as many foster kids as non-foster care kids were taking these kinds of drugs. These kids weren't even in the first grade yet. Many of the drugs that they were taking were not even approved for young children. Another study of pharmacy claims in 16 states showed that foster children enrolled in Medicaid were prescribed antipsychotic medications at a rate nearly 9 times other children receiving Medicaid. One serious mistake the system often makes is to diagnose a child who has experienced trauma with an underlying biological psychiatric disorder. And those children may exhibit the same kind of behavior that someone who may be bipolar or schizophrenic. For the life of me, I don't understand how you can, and I'm not a doctor, but for the life of me, I don't understand how you can diagnose a bipolar disorder in a child at 2 years old. And yet, we're prescribing those kinds of medication. If you remove a child from his home, the only home he's ever known, they're going to experience trauma. and then the subsequent trauma that occurs after that. You know, I've often said that if you look at a child who's in a home and he's been mistreated or neglected, that's his home. And what we do is we remove him from his home. You know, I've often said that maybe what we ought to be doing is removing the parents from the home, because the child's done nothing wrong, and yet he often perceives himself to be. I'm not anti-medication. I want to make that clear. And I think that sometimes medication as part of an overall treatment plan may be very necessary for some troubled kids. But it is not the only modality that should be considered. Sometimes that non-medication interventions are sufficiently effective in dealing with children with mild and moderate symptoms of mental illness, and are often recommended and are often should be recommended over medications. It is absolutely necessary that we enhance our efforts to make sure that psychotropic medications are only prescribed when needed and only when in the quantity needed. They should not be prescribed just to keep kids quiet or to divert their attention from other situations. You know, I looked at the national statistics. 4% of children under the age of 18 are on some form of psychotropic medication. It is higher when you get in relative care. It is higher than that when you get into foster care, and it's at the highest when you get into group care, which would lead you to the untrained individual would lead that person to believe the further you get away from the biological family, the less willing to put up with disruptive behavior, and the less willing to work with that. And clearly you can see that in group care and with the amount of kids in group care. I had experience with this in Florida with a young child, 7 years old, in foster care, who committed suicide by hanging himself. And you really kind of ask yourself, this young man's name was Gabriel Myers. And you ask yourself, how can a 7-year-old little boy even contemplate the idea of taking his own life? How can a 7-year-old boy who ought to be out, you know, learning how to play softball, learning how to catch, learning everything that a 7-year-old little boy ought to be learning, how can he contemplate taking his own life? And then you delve deeper into the case of Gabriel Myers, and here was a little boy who was removed from his mom, who was a substance abuser, who had been sexually assaulted by a relative in Ohio, was placed in 3 different foster homes over a short period of time, was placed on multiple medications, and at the time was receiving 3 psychotropic medications not recommended for children, where his therapist had never communicated with the psychiatrist who was prescribing the drugs, and the therapist changed because she moved to Europe, where he was told, because he was acting out by his new foster home, that he had to cut his hair. They took his toys away from him and told him he wasn't going on the family vacation. I don't care if you're 30 years old. If you have that kind of change over a short period of time, you are going to experience a negative impact on your personality. And yet this little 7-year-old boy was being asked to deal with all of that. In reality, you know, I appointed a task force to look at that case. And they spent a lot of time talking about the disconnection between the psychiatrist and the therapist, the impact of the psychotropic medications. But in reality, it really came down to one thing. Nobody was acting as Gabriel's parent. And if you were the parent of a 7-year-old child, and a psychiatrist was recommending 3 different psychotropic medications after that child had been on several others, you would not be accepting that kind of outcome. If you were the parent and there was a disconnection between the therapist and the psychiatrist, you would not have accepted that kind of outcome. So I really think that we can learn things from a case like Gabriel Myers and other cases, regrettably, throughout the country. So what is the Administration for Children and Families at the Department of Health and Human Services doing to address these severe cases? I can sum it up shortly. We are shifting resources to make sure that we support and promote that which actually works. Whether it's cognitive behavior therapy or home visiting, as was established in the Affordable Care Act, or other kinds of psychological first aid, we are in the midst of a significant effort to address the use of psychotropic medication among kids in foster care. We've established an interagency work group made up of the Centers for Medicaid and Medicare, Substance Abuse and Mental Health Administration, the Food and Drug Administration, the Administration for Children and Families, to get everybody on the same table instead of operating our individual silos. How do Medicaid policies impact an effort to drive to a psychotropic solution as opposed to a therapeutic solution? What impact does the Food and Drug Administration's policies have in terms of drug trials on young children, on the overall impact of what we're trying to do in child welfare? We've issued guidance to the states, and we'll be continuing to oversee what the states are doing as it relates to the use of psychotropic medication. The recently signed Child and Family Services Improvement and Innovation Act requires that states tell us how they're going to monitor, how they're going to treat the health needs of children in care, including emotional trauma and the related maltreatment and removal from homes. We're working across the department to develop new guidelines and additional guidelines as to how the states account for psychotropic drugs. We're investing in approaches that will help children heal and recover from abuse and neglect, because I think those are so important. But there are other components that are important to these children. I want to assure that these children also find stability in their schooling. And when you have a child come into care who's already behind, and then is moved from one school to another school to another school, how do you expect that child to ever get ahead? The vast majority of those kids who age out of foster care don't have a high school education, don't have basic social skills. We're also focusing on children who are aging out of the system. The transition from adolescence to adulthood is probably the most difficult for all young people. It may not have been for you, it was for me. You know, when I turned 18 and went away to college, I went away to American University in Washington. I had never left my mom, and I was 18 years old. And I can now, at 60, I can now admit that I missed my mom at 18. Was I prepared to live independently? I'm not sure about that, because there were those constant phone calls home, or that constant call home to say, hey Mom, I'm a little short this month. And Mom was always there. Imagine aging out of foster care at 18. 90% don't have a driver's license. The vast majority don't have a college education. I mean a high school education. Don't have the basic social skills to interact And that is a direct pipeline to homelessness and the criminal justice system. So what I'm saying is we've got to look at the totality of what we're doing for young people, not just these individual silos that we've given. We've also targeted funds for child-to-child protective systems seeking to improve their ability to detect and respond to children who show signs of trauma. These programs will focus on identifying children with trauma symptoms and using interventions that have been shown to help them. We're encouraging all of our grantees who work with children to concentrate on protective factors, exposing them to experiences that will make them more likely to grow into healthy adults. I'm talking about protecting them from harm and fear, helping them build healthy relationships with loving adults and with peers, and rewarding their ability to self-regulate. Educational mastery also helps. So we're emphasizing the acquisition of grade-level math, reading, and writing skills. And we're also testing innovative approaches to developing permanent placements for various groups of foster children. Kansas, for instance, is testing a program with severely emotionally disturbed children. California and Arizona are both striving to speed up the placement of African American and Native American children into permanent homes. Nevada is focusing on children with immediate safety risk. Illinois is concentrating on children who've been exposed to severe trauma. And the Los Angeles Gay and Lesbian Community Center is working in Los Angeles County to develop a model program to protect the health and well-being of LGBT foster youth and to remove barriers to permanency for them. You see, we as a system have learned how to keep kids safe. It's easy. All you have to do to keep kids safe is lock them in a room, remove them from their home, lock them in a room, give them 3 hot meals during the day, a place to sleep. They're safe. But what about child well-being? What about the well-being of that child, the educational, the health, the psychological well-being of that child? While safety is important, it is not the ultimate gauge of whether we're going to be successful as a system. It is about the well-being of that child and what that child becomes during adulthood. Again, the number of children in the system is on the decline. And I think we've got to continue that direction. But I think an important part of our strategy is what we call the 4E waiver. Right now, there is a disincentive to the system to improve the system in the child welfare financing scheme. Right now, the federal government will pay a state X amount of dollars for every child in care. So there is at least a subtle message that you need to keep children in care as opposed to taking them out of care. Because if you reduce the number of children in out-of-home care, you lower, and you know that, you lower the amount of federal dollars that you receive. And the other restriction is that you can only spend federal dollars on the child, not the issues that brought that child into care. The more I learn about child abuse, the more convinced I am it's about mental health, substance abuse, and economic stress. You deal with mental health, substance abuse, and economic stress, you will dramatically reduce the number of children coming into care. So why aren't we dealing with those issues as opposed to just the issues that that child has? But the waiver allows states to provide services to the family, not just the child. So if in fact you can keep the child safe by bringing services to the home, then you can use federal money to do that. And if you do ultimately have to make the decision for the safety of the child, it is important to bring that child into care. While that child is in care, you can provide services to mom. say mom has a substance abuse problem. Doesn't mean she doesn't love her child. But it means that the substance abuse is controlling her ability to adequately care for that child. So why aren't we dealing with the substance abuse issues of mom with federal dollars and blending mental health and substance abuse and child welfare dollars into a coherent scheme to deal with those issues? I've got a little experience with the waivers because Florida was the only statewide waiver in the country, and that I can't take credit for that because that happened before I got there. But in the reality, what the waiver did is it allowed us to reduce children out of home care by 36%. That's significant, but that should not really be the test. What should be the test is that the length of time necessary for reunification with mom or dad was cut virtually in half over that period of time, and re-abuse was down after reunification. It's because there was an attempt to deal with the inherent problem. Now, don't get me wrong, Florida still has issues it's got to deal with, but the FOIA waiver gave us some of the tools to be able to adequately deal with the issues. Let me give you an example. There's a program in South Florida called Susan B. Anthony. And what happens in Susan B. Anthony is mom goes into residential substance abuse treatment. Child stays with mom. Child gets early childhood education. And you continue the incentive on part of mom to stay in treatment and to get better. And that's the kind of thing that I think a long-term child welfare financing reform can bring to the system, is a real effort to deal with the whole family, not just with the issues facing that child. So what happened in Florida, we went from spending $1 for prevention for every $3 in out-of-home placement to spending, from $1 on prevention for every $9 in out-of-home placement to $1 to $3 in prevention, tripling the amount of money that we were spending on placement. Now, let me also point out, I don't believe that the waiver is a silver bullet, because I think you're going to still have to have state leadership that's well informed, a practice that's brought more in line with some of the research that we now particularly know about trauma and the impact of psychotropic medications. But I think it can be a positive tool to move forward. Waivers really offer the opportunity to provide a much wider array of services, like intensive in-home services, integration of substance abuse and mental health and domestic violence into child welfare, using foster parents more as mentors to biological parents, so that it allows you to really enhance your ability to have reunification, intensive recruitment and training of potential foster parents, which are such a critical component. I think when you provide more effective prevention and intervention services like these, more children can remain safely at home. But they would still get the kind of oversight and the kind of information they need. When you safely reduce the number of children in out-of-home care, you can also focus much more on improving the quality of the foster home itself. Carol Schofer from California worked with us on what we called our Quality Parenting Initiative and other programs to really allow foster parents to get the kind of training and the kind of insight to be better foster parents themselves. I think through programs like that, you can better link the needs of children with the array of placement options. But the sad fact in this whole thing is that some children just will never be reunified. There's some people who just shouldn't be parents. And I think that the extent to which we can recognize that at the earliest possible point, as opposed to the latest possible point. So I think those children really deserve a permanent family as well. It is not normal to grow up in foster care. and it is not normal to age out of foster care. I think what Charlie's Romanian studies really showed is that children really do recover when they have good parents, and the impact of that. We saw today a young child and the impact of what who ultimately wound up being adopted, and what the impact and the reality was of just the ingredient of love. We can talk about all these other theories, but ultimately the impact that love can have on a child is beyond measurement. And I think it's something that we've got to remember. I'm one of those people who believes that no child is too old to be adopted. And I think, I hear this in child welfare systems around the country, that there is a certain category of children who are unadoptable. The only reason they're unadoptable is because we've come to the conclusion they're unadoptable. I was at a adoption ceremony in Jacksonville not too long ago, and this 17 and a half year old young man was being adopted. And I said to him, probably not this bluntly, but I said to him, why now? You're going to be 18 in 6 months. And his response was, well, now I got a place to go for Thanksgiving and Christmas. Because it is not just about being taken care of until you're 18 years old. It's part of being part of a permanent family, a permanent love situation that allows you to succeed. I think that getting young children who've experienced severe deprivation into high-quality foster homes or high-quality permanent homes, those are the kinds of things that allow their brains to fully develop. The extent to which we can make that happen, I think we're much better off. We in Florida developed what we called our longest waiting teens project. I said, well, let's look at the 100 kids in the system who've been in foster care the longest. And the response was, well, we're never going to succeed in that. I said, well, let's just target those 100 kids. Within 18 months, 60% of those kids were adopted, because we finally said we're going to prioritize that. And I think as you're doing that, you also have to look at one other piece, and that is post-adoption services after adoption. Adoption in and of itself isn't the end of our commitment. And I think systems have to look at that. If a child has experienced trauma in the home, if a child has experienced trauma with removal, if a child has experienced trauma of subsequent removal, that trauma very well is carried into an adoptive home. And adoptive parents can have a huge impact on that child. But you clearly have to continue to work with them so they understand what they're dealing in and understand what they're getting. There's a friend of mine in Tallahassee. He happens to be on the Supreme Court. I was telling Dr. Zena this last night, they had 4 girls, all went to college, all graduated from college, and all of a sudden they were empty nesters. And his wife goes to him and says, we need to adopt a child. Well, he did like a lot would do and resisted that. We're now free. We now have this big house, and she said, well, you like being a judge, don't you? And he said, yeah. She said, as a matter of fact, you love being a judge. And he said, yeah. He said, what would you do if somebody told you couldn't do that anymore? And he said, well, I wouldn't be happy. She said, well, I love being a mother. And so they finally said, all right, we're going to adopt. And he thought, well, we'll just adopt this nice little month-old child. And well, she goes online and finds a set of 3 siblings. And the oldest sibling is 12, and there's a 5-year-old and a 4-year-old. And she reads that this 12-year-old says, adopt my two brothers because I'm too old to be adopted. Well, you know the rest of the story. So they adopted those three kids, and they were doing great. And a year later, biological mom had a fourth. And then a year later, she had a fifth. They're now up to 6 children, all with different fathers, all substance abuse children, all with individual issues that they're having to deal with, even though they're now getting them virtually at birth. But it is, plus they have the financial resources to deal with this and a house big enough to deal with this. But they still have to deal with the issues of each of those individual children. And in this case, biological, physical issues that those children are going to be going through over the period of time. But they are full of love and import. Another component I really want to talk about that I learned from these young kids was virtually every foster child I talk to, you ask them what they want, and they say they want to be normal. They don't want a iPad or the new Wii game. Most things they want is to be normal. And we in child welfare, we don't even use normal words. Think about it. Most children will be in 4 or 5 different homes or houses in their life. Foster children are in 4 or 5 different placements. Parents need a vacation. Foster parents need a vacation. Foster parents need a respite care. It's the kind of words that we use. And then we say to foster children, how many of you have children? That's a fair representation. When those children get to be 12, 13, they want to do sleepovers. And but too often we say, well, the liability of that, Johnny, foster child Johnny, wants to do a sleepover down with his friend Jimmy down the street, and we say, well, first of all, we got to do a criminal background check on those parents. Then we got to go in and do a home study. First thing, Johnny doesn't want to admit he's in foster care in the first place. So instead of saying, well, I'm in foster care, this has got to happen, he basically makes up another excuse. I went to a meeting in St. Petersburg and spoke to a group of foster parents. And before the meeting, this woman came up to me and she said she was having trouble with our dangerous activities czar. And I said, what are you talking about? She said, well, you have a dangerous activities czar. I said, no, we don't. She said, yes, you do. Well, we did. I've come to find out, and I'm running the department, I come to find out that we have this woman in Tallahassee who approves what activities foster children can participate in. Well, Jimmy can participate in Boy Scouts, but he can't participate in archery because it's dangerous. And we have done so much in the name of preventing liability that we have created cocoons around foster children. And we've taken them and said, well, we've got to protect, and I don't know whether I have a feeling it's not really to protect the foster child, it's to protect the system from liability. And we've created these cocoons around, and then we wonder why children at 18 years old age out and don't have social skills, don't have high school education, don't have the ability to interact in the real world. So I think that there are a lot of things that we begin to ask, and I think we ought to start asking ourselves in government, is what's the right thing to do? And then figure out how the rules apply to it, as opposed to designing a system that is so geared towards let me kind of put this in perspective. I think the President's budget proposal is really supporting our efforts. In the 2013 plan includes an increase of $250 million targeted towards innovation in the child welfare system. Incentives to states who want to improve their systems, in addition to the 4E waiver. I think that is an important piece. Hopefully Congress will act favorably on it. And I would also be remiss if I didn't add an additional component to this, and that's the Affordable Care Act. And if you really look at what makes children and families vulnerable, primarily it's two things. It's access to health care and it's access to education. If you give people access to education and access to health care, they can become productive members of society. And I think that since the Affordable Care Act was passed, there are a lot of provisions that have already rolled out. But one of those provisions is that children are now, on their insurance policies, have to be insured for pre-existing condition. Now, children under the age of 26 can stay on their parents' policies. Now, children get preventive services for free, services like routine well baby and well child visits, routine vaccinations, oral and vision care. And I think it is important that we recognize the improvements that states can do in the child health insurance program, because all of those things are elements. And I think this is important to the child welfare system, because children who come into the child welfare system are eligible for Medicaid as well. And we're trying to loosen up some of the federal guidelines as it relates to Medicare in this arena. But another component is also the home visiting program. I am a big believer in home visiting. If you can deal with some of the issues in the home, and I've been saying that throughout my comments, if you can deal with some of the issues in the home and deal with some of the inadequacies of the parent. I went on a visit with a home visitor and talked to a mom who had a 5-year-old. And she had been in the home visiting program for about 1.5 years. And her reaction was, she said, you know, that's the way I thought you were supposed to discipline your child, because that's the way I was disciplined. And I think we recognize that a lot of children are having children, a lot of individuals without basic parenting skills. And I think those are such an important component for us to be dealing with. I would ultimately like to see a national coordinated approach where the federal government, the states, and local governments, and the private sector really work in a coherent way. The program that we went to this morning, the infant team concept, I think is an example of that. And where you really have an educational institution, a not-for-profit institution, and the state working together for the best outcomes for children. And I think that we can get there. I mean, there are so many, today there are so many prophets of doom. I mean, think about it. You go around there, America's best days are behind us, we'll never be great again. There's some kids you just can't save. I mean, you hear it all the time. I decided to be an optimist. And frankly, the reason I decided to be an optimist is I looked out there in the field of pessimism, and there's just too much competition. You know, I will never be the best pessimist, but I clearly can be the best optimist. And I think that's the only way we're going to move the best outcomes for children forward. And I think Frederick Douglass put it best when he said that it's easier to build strong children than it is to repair a broken man. The efforts that we can put into young kids have long-term payoffs. And that's not just in the child welfare system. What's happening today in terms of our reinvestment in early childhood education, with the research that we know that the vast majority of brain development happens in those first 5 years. There are so many things that we can learn from you. There's so many things that we can learn from researchers. And what I hope is that we at the federal level really begin to listen in a coherent way to what is out there in terms of research, begin to work in a coordinated way with our states, and begin to move this system a little bit further forward. Thank you very much for the opportunity. It's good to be in New Orleans.
couple of questions.
As long as they're easy.
Just a comment, you talk about trying to develop a network that combine resources of different agencies. One, it would be helpful is the GME program that feds do. Those GME studies are tied to
Graduate medical education.
Okay.
if we were able to use those in the community somehow, as opposed to being tied to a hospital, that would help, especially with the physician shortage and with, especially with child-related mental health. So if there's a way that we can switch some of that. Also, at one point, right before 9/11, they were looking at funding psychology intern slots similar to the GME funding. And that would be something we would be interested in, not only the psychology interns, but the postdocs, as a way to fund them inexpensive, but it creates the pipeline for the future because we have such a shortage. And then the other thing I think would be helpful is when you deal with Medicaid, a lot of what is happening in the home setting and dealing with these children or dealing with security issues don't have a DSM diagnosis in order to be reimbursed by Medicaid. And if that could go, I think that opens up a pipeline to providers.
Yeah. First of all, I'm not as familiar with the GME program. Great. But I will say, in general, what the administration is trying to do is break down some of these silos and also provide more flexibility. We have what's called our health professions occupation grants that we're now rolling out to get the working poor into the health professions. And I was with a group of young women who, about 6 women who were on track to become certified nurses' aides, but they had been, 6 months earlier on a welfare dole. So I think there's some of that. On the CMS issues, and I'd be happy to get some more information because I don't mind dealing with this graduate issue to the extent I can, but even though it's a different department. And we have a much better relationship now with the Department of Education than I think has existed in a long time. On the issue of the Medicaid, I've met with our Medicaid folks, and because I was always told in Florida that in order to access therapeutic reimbursement by Medicaid, you had to have an underlying psychiatric evaluation. I don't think that's true. And I think to a large extent, states I think, need to have a greater clarification of what Medicaid is actually saying. And Medicaid understands that. So I think that what really is regulation and what isn't. And I'm not sure that there's the rigidity on that piece as some people may believe there is.
So I want to thank the School of Public Health.
One more question over here.
Using their space, but there's a class waiting to get in, so
I'll talk to you.
have to move things along. So
thank you very much. I appreciate it.
Thank you.
Thank you.